Knee pain is one of the most common orthopedic conditions and a major reason for disability. Your X-ray or MRI says you have arthritis or a meniscal tear, and I say, so what? And I'm going to explain to you why you should probably say that too. Hey, it's Glenn here from Mehab, the world's leading physical therapy alternative, where we educate and empower you to take control of your recovery. If you're new here, make sure you click that subscribe button. Any links we mentioned in the video can be found in the description below. As always, the information we provide is for educational and demonstration purposes only. With that out of the way, let's get into it. If you've been to your doctor for knee pain, depending upon your symptoms, they may order an X-ray or MRI to help figure out the cause of the pain. The question is, how much do they really help? And the answer is not as much as people think. Imaging, X-rays and MRIs, are used to get a more detailed look into the body and how it is functioning. They are often used to diagnose arthritis, meniscal tears, fractures, etc. MRIs in particular are great at providing detail of structures in the knee, which at first sounds like a great thing. However, while these scans are great at identifying abnormalities, they are very poor at telling us if these things are the cause of your pain. It would seem logical to associate your pain with a problem that appears in your MRI, but don't be fooled. It's not quite that simple. A recent study imaged 230 people's knees without pain and showed that abnormalities were present in 97% of their knees. 30% had meniscal tears, 62% had cartilage defects, 52% had bone marrow abnormalities, tendon damage appeared in 46% of the pain-free knees, 38% had an ACL, PCL, MCL, or LCL abnormality, but no pain. To simplify, knee problems that are found on MRIs appear frequently in people without pain. X-rays and MRIs are just a small piece of the puzzle, and any abnormality should be considered a small step towards understanding the patient's pain, rather than a big arrow pointing to the source or the cause. Imagine two tennis players each holding a tennis racket backwards. Now tell me who's the better player. You can make assumptions and try and justify your choice, but the truth is you have no way of determining the worst player based solely upon those images. Nonetheless, people often have interventions and surgeries to fix abnormalities seen on an image that are in fact perfectly normal. There are situations when imaging of the knee is a good idea and would likely show abnormalities that have a higher likelihood of being the cause of pain. The first one is traumatic onset. Pain that presents without any specific mechanism of injury is unlikely to show anything of relevance on imaging, whereas imaging after some sort of accident or event may be of value if pain is present. Next is severe unrelenting pain. Pain that is severe and never dulls down regardless of rest or positioning would warrant further investigation. The third is failed conservative care. If someone has attempted conservative care of a knee injury through rest, time, or physical therapy and made no progress, imaging would be warranted for further clinical assessment. So next time you have knee pain, it is unlikely, excluding the previously noted reasons, that there's a need to rush out for imaging. If you do get imaging, there's probably no reason to worry about the findings like osteoarthritis on your X-ray or a meniscal tear on your MRI just yet. They should be considered irrelevant until proven otherwise. Findings on an X-ray or an MRI are only considered relevant if they correlate to a patient's signs and symptoms. Before you go, check out some of our other videos, give us a like, click the subscribe button and make sure you turn on notifications so you don't miss any of our other videos. Thanks for watching and we'll catch you on the next one.